I wanted to welcome you from My Horse University to our live web presentation featuring Dr. Schott. He will be discussing tonight equine Cushing's disease, challenges of diagnosis and treatment. Dr. Schott received his DVM degree in 1984 from the Ohio State University College of Veterinary Medicine. He started his career with 3 years in private equine practice in Southern California. Subsequently pursued advanced training by completing a residency in equine internal medicine and a PhD at Washington State University. Since 1995, he has been an equine medicine clinician at Michigan State University with a strong clinical interest in urinary tract disorders, respiratory disease, and other disorders as well. In addition, he continues to pursue a research interest of fluid and electrolyte balance in the endurance of horses. If you could please welcome Dr. Schott tonight. And also, I just wanted to note that we are recording this presentation, and it will be available on the My Horse University website at www.myhorseuniversity.com.
Well, welcome to all of you this evening. I look forward to spending some time here, and we'll talk about Cushing's disease. This is my first web presentation, so it's a little different than standing up in front of a group of people, but we'll see how it goes. Again, welcome all of you from hopefully around the country a bit. As Kate introduced me, I am here I'm an internist, a doctor looking at internal medicine problems of horses here at Michigan State University. And as all of you are aware, interest in endocrine disorders has just risen exponentially in the last 10 to 20 years or so. And along with that, I've developed a strong interest in endocrine disorders as well. So we'll go on here to the next slide, and basically we're going to use the term tonight, pituitary pars intermedia dysfunction. And this is sort of the newer accepted term is the best descriptor for what we call equine Cushing's disease. And I'm going to talk a little bit about some of the challenges we have to diagnose this disorder, as well as our current recommendations for approach to treatment. This picture here shows three horses, or as you can see, horses and ponies, basically showing that this condition can affect horses and ponies of all shapes and sizes. And you can see here the shaggy long hair coat, which is very characteristic of the disease, probably the most common cause, and or a clinical sign, and we call that basically a pathognomonic clinical sign. In other words, there's really no other disorder of horses that causes that long shaggy hair coat that fails to shed. I'll acknowledge Han van der Kolk from Utrecht University in the Netherlands, who provided this image to me. And Dr. van der Kolk has spent a lot of his career looking at endocrine disorders of horses as well, and has done a lot of work with Cushing's disease. And during our presentation, I'll show you a little bit more of his previous work. So Cushing's disease, or pituitary pars intermedia dysfunction, as I've already mentioned, all breeds and types of horses or equids, because we can have horses and ponies, are affected with this condition. But it's fairly clear that Morgan horses, or the Morgan breed, and ponies tend to be overrepresented. And that is, it's more common in those types of horses. Some of the earlier studies suggested that mares might be a little bit more likely to get it, but more recent review of cases shows that there really is no sex that's more likely to be affected, whether it's mares or geldings or stallions. And this long shaggy hair coat is basically, again, this sort of pathognomonic clinical sign, and the term for that medically is called hirsutism, and it's a long hair coat that fails to shed. Some of the other clinical signs that we see in horses may be increased sweating. About a third of them will have some increased drinking and increased urination. And then as the disease progresses, we'll also see some muscle wasting in response to the extra cortisol that's circulating in the bloodstream. And here's a nice example where we can see the hollow out back in the picture in the middle here of some muscle wasting that occurs predominantly over the top line and up over the rump. Occasionally we'll also see with the long shaggy hair coat that we can have a discoloration or a change in the hair color, as well as illustrated by the picture of the horse on the right. These horses are also can be a little bit more docile, and they also tend to be a little bit more tolerant of pain. And one of the explanations for this is that if we look in the spinal fluid of affected horses, they may have 100 times higher level of a endogenous hormone or a brain hormone called beta endorphin. And beta endorphin is a hormone that tends to be released in situations where there's stress, and can again make a horse or a person more tolerant of stressful stimuli. It's the hormone that people talk about when long distance runners go out and get sort of a runner's high. The beta endorphins increase. So that's one of the characteristics that can go along with these horses. The other clinical signs that we see is that they are more prone to chronic infections. And one of the more common infections is an infection of a tooth root. And if it's affecting one of the upper cheek teeth, as we have an example here, we have an upper tooth root infection. From the outside, doesn't look very abnormal, but the characteristic thing is this nasal discharge, often from one nostril, and it'll often have a fairly foul odor associated with a tooth root infection. And in that situation, these infections also are slower to respond to antibiotics. And this is the same horse that has a wound here on its lower lip, and we can see this ulcer that's formed there. And these wounds tend to heal more slowly. Some of the other clinical signs that might occur with Cushing's disease are persistent lactation, and we don't really clearly understand all the hormonal imbalances that are going along here, but we can see the udder here of a mare. In this situation, they can have persistent lactation, and despite the fact that they're older horses, they also tend to have some fertility problems as well. Some of the theriogenologists or reproductive experts that work with them will find that they can get these horses in foal, but oftentimes it's difficult to maintain the pregnancy to the time to deliver a healthy foal. Okay. Additionally, in the earlier stages, before we have muscle wasting, sometimes we'll have abnormal fat deposition, and this characteristic cresty neck, as we can see on the picture on the right, and a little extra fat up over the rump on the picture on the left. And in this situation, one of the concurrent problems that goes along is that these horses, some of them may be resistant to the effects of the hormone insulin and get a secondary, what we call a type 2 diabetes, or an increase in blood sugar that may occur in some of the patients. Now, this insulin resistance, many of you have heard of that syndrome by itself, and so insulin resistance syndrome can be a syndrome by itself in middle-aged to older horses where they do have abnormal fat deposition and are prone to foundering or getting laminitis, but that's a separate syndrome that appears to be this Cushing's disease. With Cushing's disease, one of the components can be additional insulin resistance, so we'll try to stay on this talk specifically with the Cushing's disease. Here's our big problem. We have the horses, we can tolerate the long shaggy hair coat. That usually doesn't cause us too much of a problem. But about half the horses affected by Cushing's disease tend to founder or get chronic laminitis. And so this painful condition, usually affecting the front feet, is what really is the most intensive management part of the program. Here we can see the feet of a pony on the left upper area was when we first evaluated the pony, and the feet don't look that bad, but actually at this point the pony was the most clinically lame. As we worked with this pony over the next 6 months, the foot progressively started to grow out and actually starts to look more atrocious over time, but actually over here on the right the pony was quite sound at this time and could be used for riding again. But with laminitis, it requires proper foot care and good attention to getting a good farrier involved in the program. Let's see our next slide here. So this is a summary slide of clinical signs that were seen in nearly 160 equids. So I have 159 equids in 6 case series. These were published in the literature, and then in a publication I wrote in 2002, we summarized these clinical signs. And again, at the top of the list is hirsutism, or the long shaggy hair coat, then followed by muscle wasting, chronic laminitis, increased urination, sweating, and abnormal fat deposition. We have a range in which these signs were reported here in the right-hand column, and then in parentheses is sort of the average. And the average is probably the most important to look at because that's the summation over the 6 case series. And what we can again see is our big problem of chronic laminitis affects about 50% of these horses and ponies with Cushing's disease. And the laminitis is unfortunately often the reason that euthanasia is eventually performed. In many cases we can control the signs of laminitis, but it is a recurrent foot problem, recurrent lameness, and predisposes the horses to recurrent foot abscesses as well, and that causes them again a period of pain and is just difficult to deal with for both the owner as well as the horse over time. So, a couple of questions to start out with here. Equine Cushing's disease. A lot of people think it's really on the increase, okay? And unfortunately, at this point, we really don't know over the last 20 or 30 years, is Cushing's disease becoming more common, or is it simply that you as horse owners are demanding better care of your older animals, and other practices in equine medicine and surgery have improved our just management and care of older horses. Clearly, the production of the senior type feeds have made it quite a bit easier to manage the horses as they grow older and their teeth are no longer able to effectively chew hay. And as you can see on the bottom picture here, there's been a lot of advances in equine dentistry in the last 10 to 15 years to try to maintain the horses to have cheek teeth that can grind hay for a greater period of time. Just recently, in the month of June this year, at our internal medicine annual meeting, where we have about 2,000 veterinarians and many of the equine internists joined there. This meeting was out in Seattle, where there were some investigators from Queensland, Australia, that tried to look at how common equine Cushing's disease is. And they had 2 studies here, and in the first study, they asked owners of horses, and these were sort of pony club equivalent horses in the Queensland, Australia area. And they sent out a questionnaire to these, and they basically asked, how often do you see hair coat changes, and how often do you see laminitis? And they specifically selected horses over 15 years of age. And they found in this study that hair coat changes affected about 20%, or 185 out of 963 horses to which we had they had survey responses. And about 5% of the horses suffered from chronic laminitis. And that fits with other estimates of Cushing's disease affecting somewhere between 15 and 30% of horses, probably more realistically over 20 years of age. In the second part of the study, they looked at the prevalence of this equine Cushing syndrome based on some elevated hormones which would support the disease. And they looked at a subgroup of that, about 339 horses, or about 30 of those horses. And they found in this situation that 2 hormones, alpha MSH and ACTH, 2 hormones produced by the abnormal pituitary gland, were increased in about 15%. So again, this would support, again, a prevalence somewhere between 15 and 20% in older horses. Now, I want to do a little comparison of Cushing's disease in horses and people and dogs. What we have here is an illustration of the base of the brain called the hypothalamus up here in gray, okay? And what we have in the different colors are nerves coming out of the hypothalamus, and they come down into this gland, the circular structure here below it, which is called the pituitary gland. The pituitary gland is a master sort of hormone gland of the body. It controls lots of other glands like the thyroid gland, the sex glands, the adrenal glands, which is where the extra cortisol is produced with Cushing's disease. What we see here is there are 2 parts of the pituitary gland in this schematic in people and in dogs. A back portion, or a posterior, or a front portion called the anterior pituitary gland. Now what happens in people and in dogs is they get a small benign tumor. In other words, it's not malignant to spread to other parts of the body. A benign tumor that unfortunately does produce extra hormone called ACTH. This is adrenal cortical thyrotropin, and adrenocorticotropin actually stimulates the adrenal glands then to produce more cortisol. In horses, we have a little bit of a difference. I showed in the last slide two portions of the pituitary gland. Okay, this one's sort of turned the different way. This is the front of the pituitary gland and the anterior lobe. Here's the posterior inferior lobe here. Now this small little gray band in the middle is what's called the pars intermedia, an intermediate portion of the pituitary gland. It tends to stay fairly small, but it does have some important functions in terms of hormone production. If we go on and look at what these pars intermedia melanotropes do, is they secrete a slightly different hormone, which we'll get to in a second. But in horses, the Cushing's disease in horses is not a problem of this anterior or portion of the pituitary gland like in people and dogs. It's a problem here of this intermediate portion. And what happens here is we get increase in the number of cells called hyperplasia, or a small tumor called an adenoma, either micro or macroadenoma of the pars intermedia. Now, this allows production of a different hormone called POMC, which is pro-opiomelanocortin, and then that's broken down into some other hormones which have ACTH-like activity and will work on the adrenal glands to make more cortisol. Because it's a problem of the pars intermedia, we've gone away from calling this syndrome Equine Cushings Disease, although I'm slipping many times and referring to it to that. But the new preferred term again is pituitary pars intermedia dysfunction. This emphasizes that the disease is affecting the pars intermedia, and the word dysfunction on there means that we have to have clinical signs or clinical syndrome associated with this dysfunction. Now, what's interesting is over the last few years, we've also started to recognize that this is not a disease of the pituitary gland primarily. Rather, the portion of the brain that sits right up on top of the pituitary, called the hypothalamus, undergoes some loss of the nerves there. And so there's actually a degeneration of the nerves of the hypothalamus. These nerves normally innervate that intermediate portion of the pituitary gland. And those nerves actually tend to turn off production of hormones by the pars intermedia melanotropes. So when we lose these nerves, what happens is the pars intermedia melanotropes start to grow and start to produce hormone because they're no longer regulated by these dopaminergic neurons from the hypothalamus. Now, this loss of dopaminergic neurons causing PPID, the abbreviation for pituitary pars intermedia dysfunction, appears to be an age-related phenomenon in many horses. As we all get older, we start to develop wrinkles and memory loss and all these kind of things, and the underlying problem associated with that appears to be what's called oxidative damage or oxidative stress. That's why we're often told to take things like vitamin E and vitamin C and other antioxidants to try to slow that process down. Unfortunately, it's most likely controlled in our own DNA or our own genetic makeup on how susceptible we are to oxidant-induced damage. Well, very interesting, some recent work by a woman named Diane McFarlane, who did her PhD on Cushing's disease up in Atlantic Veterinary College in Canada, found that in the dopaminergic nerves that were degenerating with Cushing's disease in horses, they accumulated a protein that's shown here called alpha-synuclein. Now, why this is very interesting is that these pictures here are actually nerves from the hypothalamus of humans with Parkinson's disease. So it appears that the loss of these dopaminergic neurons is a way very similar to the degenerative process that occurs with nerves in people that develop Parkinson's disease. And I think if you think about that, we recognize that Parkinson's disease develops very, very slowly over a number of years. And then the obvious question is, why don't horses with PPID have the shaking or the tremor problem that people with Parkinson's do? And the explanation for that is not the exact same population of nerves is degenerating with Cushing's disease. It looks like the same underlying process, but a slightly different nerves, and that's why we have the difference in the clinical signs. Okay, so let's go back here. This is a microscopic section here of the pituitary intermedia, or the pars intermedia, this little gray band in the middle. It's going to make this hormone, POMC, pro-opiomelanocortin, in excess because the nerves are no longer stopping the production. This is cleaved into two hormones, ACTH, adrenocorticotropin, which we mentioned before, and another one called beta-lipoprotein. Well, these are cleaved a little bit more and processed into further hormones, and this gets pretty complex here, but the net effect is this ACTH and some of these other hormones end up stimulating the adrenal cortex to make extra cortisol, and we end up with a syndrome of cortisol excess. Now, I mentioned earlier the beta endorphin in the spinal fluid, and you can see the beta lipotrophin goes over here and gets processed to beta endorphin, so we have high levels of that as well. So if we think about this, this helps us understand some of the drugs that we might select to treat the disorder. The next step would be that we know the production of this POMC peptide or protein is regulated by dopamine from those hypothalamic neurons. The dopamine has a negative influence on POMC, so it decreases production. Another neurotransmitter or little chemical from the brain that can increase the production of the POMC is called serotonin. So our drug pergolide, our drug pergolide, or in Europe they use a similar drug called bromocriptine. These are very much like dopamine. When we give them to the animal, it replaces some of this lost dopamine. So our pergolide tries to replace this process to decrease production of the POMC. If we decrease production of the POMC, we decrease production of the rest of the cascade. The other drug that you may have heard of, or you may have heard of using, is cyproheptadine. Cyproheptadine blocks the other side, so it blocks the effect of serotonin. So those of you who are thinking ahead could recognize that certainly in some horses we could use both of these drugs in combination, pergolide and cyproheptadine. A final drug that's been used a little bit more in the United Kingdom is trilostane. Trilostane is a drug that actually blocks the production of cortisol at the level of the adrenal gland itself, not up at the pituitary, so it helps block the increase in cortisol. I have here term hyperplasia. Hyperplasia would be an increase in size of the adrenal gland, and that's a common occurrence in dogs with Cushing's disease. However, it looks like about less than 20% of horses have actually an increase in the adrenal cortex, which to me makes the idea of treating with trilostane a little less likely to be effective in horses as compared to trying to treat the pituitary component of it. So hopefully you're not thoroughly confused right now by going through that, but I hope that background material helps you understand some of the things that we're thinking about when we approach the diagnosis and treatment of this disorder. So what are our diagnostic challenges? First of all is a clear case definition. It's not too hard to make an over-the-fence diagnosis of a long, shaggy, hair-coat horse and say, oh, that one has Cushing's disease. But I think our big challenge right now is what do we do with the horses that are between 15 and 20 to 25 years of age that really don't have a long, shaggy hair coat, but develop laminitis or founder. And they founder for no apparent reason. They haven't gotten into a 50-pound sack of grain. They didn't have colic or another problem. And so one of the questions is, can laminitis or can founder be the only clinical sign? Mark Donaldson was one of the field service veterinarians at New Bolton Center at University of Pennsylvania's veterinary clinic. That's where Barbara was. And he looked at that in his field practice horses, and he found that there was elevated hormone concentrations of some of the horses he saw in the fall that had only laminitis. And that was published back in 2004. So yes, laminitis might be the only clinical sign. The problem was we later recognized there's some seasonal variation in the hormones that made interpretation of this paper a little bit difficult. So take-home message number one that I'd like you to go away from this is that if you have an older horse, older than 15 years of age, that develops what I call insidious onset laminitis, in other words, laminitis for no apparent cause, evaluation for pituitary pars intermedia dysfunction may be warranted. You need to talk with your veterinarian, obviously, to decide whether that should be pursued. And we should also attempt to make a different or discriminate between this peripheral or this pituitary pars intermedia dysfunction, or classic Cushing's disease, and this newer syndrome we recognize called insulin resistance syndrome or equine metabolic syndrome, or the current sort of preferred term is endocrinopathic laminitis. Those horses do not have the long shaggy hair coat and have founder as the predominant clinical sign, so your veterinarian can help sort that out, whether it's classic Cushing's disease or perhaps this other disease. Now, so again, what is the best diagnostic criteria? As we've already mentioned, just an over-the-fence diagnosis of the long hair coat is actually not too bad. However, what we would like to do is a little more thorough evaluation to see what's going on with the rest of the horse, look in its mouth, check out and see if any dentistry is needed, talk about nutrition, look at the overall body condition of the horse. So in addition to clinical signs and a clinical exam, we also would like to have some endocrine tests that would support the diagnosis of Cushing's disease, and these endocrine tests would actually be more useful in the earlier stages of the disease before the long hair coat becomes easily recognizable. Some of the challenges that we have with these endocrine tests is we'd like to have a test that has repeatable results, and we'd like to have a test that we could come out to your farm any time of the day or night, pull one sample of blood and get a sample and measure a hormone and get the diagnosis. Unfortunately, that's problematic, and we don't have a test like that at this time. Here's a list of diagnostic tests that can be used to diagnose PPID. And we always tell the students that when we have a list with 9 or 10 things on it, it means none of them are all that great. If there was a single test that was very reliable, that's all we would use. At the top of the list, we have 3 of these in this color here that are probably the most accepted. Again, the clinical sign of hirsutism or long hair coat is the classic clinical sign and pretty supportive of the condition. Unfortunately, it appears to be a little bit of a later stage sign. The 2 hormone tests that have probably been used the most are looking at the plasma or the blood ACTH concentration. Again, that's one of the cleavage products of the POMC, and that can be elevated in horses with Cushing's disease. And the other test that you probably have heard of is the overnight dexamethasone suppression test. And those are the 2 I'm going to concentrate on here. I'm not going to really go into the rest of these because of time this evening. So, plasma ACTH concentration. The nice thing about this is we can go out and just take a blood sample. And the original publication on this was back in 1996 by Laurent Coutel at Purdue University. And he found that horses and ponies that had a concentration of ACTH in the blood above these 2 values, we have different units, so 45 picograms per mil or 10 picomoles per liter, depending on which laboratory you use, it would be supportive of Cushing's disease. The real nice thing about this test, it's a single sample test. We don't have to give any product that is risky like dexamethasone, which we'll talk about in a minute, and this is commonly accepted as a good test. Some limitations to this test is that different labs may provide slightly different results when the plasma or the blood is analyzed, and sample handling can be a problem. We have to keep this sample cold, and we can't leave it in a glass tube because the ACTH can stick to the glass. So sometimes we need special tubes to collect it, and your veterinarian needs to keep it on ice, or keep it cool until they can get back to their clinic and spin it down. A couple other things that are challenging here is that if it's elevated, it's supportive, but we don't really get tremendous information on the magnitude of elevation. So in other words, if we have a horse with 50 picograms per mil and a horse with 100 picograms per mil, both of them it's supportive of Cushing's disease, but the one with 100 doesn't necessarily mean that horse is any more severely affected. And then more recently, we've recognized there's a problem of seasonal variation. In other words, a lot of normal horses will have an elevation in ACTH in the fall months, and it looks like that's associated with a decreasing day length and just a normal activation of the pituitary gland to prepare horses for the winter time, to try to get a little bit more fat laid down to prepare for the harsher months, and also to try to control some of the other hormonal systems. So we really can't use it in the fall months. Just to look at that a little bit more, this is another publication that Mark Donaldson, again from New Bolton Center, published a year later than his previous study about laminitis. And he was just trying to look at ACTH in a group of 29 ponies and a group of 10 mares. These 29 ponies happen to be what's known as a feral herd, or a herd that lives outside all the time, that Sue McDonald at New Bolton Center studies for behavioral projects largely. So these horses are outside all the time, and they're not handled too much, I should say, the ponies. The 10 mares in the study were mares that are kept at New Bolton Center to teach the students how to palpate the reproductive tract so they can start to learn how the ovaries and the uterus feel. So these are basically healthy animals, and none of them had clinical signs of Cushing's disease. So he first took blood in January of 2003, and then again in May of 2003, and then September of both 2002 and 2003. I need to back up and say that actually the initial blood was collected in September of 2002. And a surprise to him was that many of the horses had an elevated ACTH in September. Here's the cutoff value, this line going across. So everything above there would be considered to have Cushing's disease, but they didn't have any clinical signs. So that was fairly perplexing in September of 2002. He came back in 2003 in January and May and found that they all looked normal, repeated it to make sure it wasn't a fluke in 2003, and again found the majority of them had elevated concentrations. He also did this overnight dexamethasone suppression test and found that actually only 29 of 39 had normal dexamethasone suppression test results in September. That says the remainder here, so 29 had normal, or 10 had abnormal test results in this time of year. So it looks like the season will also affect the DST results. So what is the overnight dexamethasone suppression test? Well, the overnight dexamethasone suppression test was developed by a group of investigators at the University of California, Davis in the late 80s and early 90s. And Noelle Dibdahl was a veterinary pathologist that did her PhD on Cushing's disease and published this in 1994. And what this graph shows is the cortisol concentration in the blood on the y-axis, or the vertical axis, and time on the x-axis. When we give a dose of dexamethasone, that's a cortisol-like synthetic hormone. And so that cortisol-like synthetic hormone should tell the horse that it doesn't need to secrete any more ACTH and cortisol from the adrenal gland. So it suppresses the natural or endogenous cortisol. And it tends to have that effect for about 24 hours. The lower line here, starting at about 4, and the dexamethasone is given right here, about 20 milligrams to a 1,100-pound horse or 500-kilogram horse, and then blood is collected again about 15 and 19 hours later. In normal horses, all 18 of 18 normal horses had the value of cortisol below 1 microgram per DL at 15 and 19 hours. So what happens in the Cushing's disease horses, or the PPID horses, is that their hypothalamic pituitary axis, the brain and the pituitary gland, do not respond appropriately to the dexamethasone. So here, after 15 hours, only 2 of the 43 horses had a value below 1, and at 19 hours, none of the 43 horses with Cushing's disease had suppression. So they fail the suppression test and maintain a high cortisol level in their blood after the dexamethasone. The advantage of this test is it's really what we call a dynamic test. We stimulate the system, and failure to respond supports the disease. An appropriate response over here says the disease, at least clinically important disease, is not yet present. Okay. We've simplified this for many veterinarians because trying to get to the farm 3 times an afternoon before, usually around 5 o'clock in the afternoon, and then twice the next morning, we often just collect 1 follow-up blood sample at 17 hours after the dexamethasone. Now, for many years, dexamethasone suppression testing was considered the gold standard test for this disease. The real advantages, again, is it's probably more accepted by most veterinarians and researchers. Another real advantage for your veterinarian is that the blood samples are very stable. It doesn't require any fancy sample handling, and many commercial labs will measure the cortisol, and it's fairly repeatable between labs. So it's a little bit easier in terms of sample handling. The disadvantage is there's multiple client visits. Again, we can modify the test to the 1 follow-up sample. And there's a concern that the dexamethasone dose can exacerbate the founder, or the laminitis. This is a potential problem, but it is relatively rare. So I tell people it's less than a 5% risk that we're going to exacerbate the laminitis. We used to think the results of this were highly repeatable, but there's been a little bit of work that questions that. And also, it probably misses the earliest stages of the disease. The dexamethasone is a very potent stimulus of this of suppression. And so when there's early disease going on, the gland normally still can be suppressed, and we see a decrease in the cortisone. So unfortunately, it's not helping us out to detect the earlier stages of disease where laminitis might be the only clinical sign. We just finished a project earlier this spring here at Michigan State University in which we looked a little bit more about whether or not the overnight dexamethasone suppression test can be affected by season. The work by Mark Donaldson suggested that there was some problem in September, but it would appear to be more reliable in September than just did ACTH concentration. So we looked for some aged horses in the central Michigan area, and we got about 5 farms to participate in our study. And what we looked at was 18 aged horses. We wanted to look at them nearly 20 years of age, and our range of age was 19 to 40 years, with an average age of about 24 years old. We had a split 10 males. We had 8 geldings, 2 stallions, and 8 mares out of these 18 horses. And we preferentially selected Morgan horses because they tend to be overrepresented. So we had 8 Morgan horses and 10 of other breeds that you can see in parentheses. Again, I want to emphasize, we're doing the test in horses that didn't have any clinical signs of the disease. So this was old horses without clinical signs of PPID. They were deemed healthy on the basis of initial physical exam. We estimated their weight. We did not attempt to evaluate diet during this test. But what we did is we went out and performed the dexamethasone suppression tests monthly for 1 year. And here's an example. This is one of the horses who is a 25-year-old thoroughbred that actually happens to live in my backyard. And what we can see is we started testing in November of 05 on him. And if we look in May 06, he's a little bit of an older horse, a little bit decreased body muscle through the top line, but he shed out very nicely. And by November 06, so he certainly doesn't have hirsutism. He's never found it. He has no other clinical signs. My wife and my daughter were helping me out there. So we had, again, a group of older horses without clinical signs of Cushing's disease. And we're going to look at the test results as either NS, non-supportive of Cushing's disease, or a normal suppression. Or results that I'll abbreviate as S would be supportive of the disease. We started testing horses between the months of November of 2005 and April 2006. And at the start, we were lucky in that all 18 horses had initial results that said they did not have Cushing's disease. We were also quite fortunate that all 18 horses completed the study year with no reported medical problems. So all these old-timers did well for the year. Interestingly, one horse in the study year had to be body clipped in April and again in July. So we did start to see evidence of some hirsutism, but all the test results, all 12 months, were non-supportive of Cushing's disease in that horse. So there's always individuals that seem to be exceptions, and that's one here. One of the things I really want to emphasize that this study highlighted for me is that when we did 18 horses in 12 tests, 12 months, that was 216 of these dexamethasone suppression tests, we had no exacerbation of laminitis or no induction or cause of founder by any of these doses of dexamethasone. So to me, I was more comfortable that this disease or this test is relatively safe. There was one horse that was reported to be sore-footed prior to testing in August, but it was no worse after testing. Now clearly these horses did not have laminitis prior to this, so horses with chronic laminitis we still might have reservations about giving the dexamethasone to. But here in these 216 tests we had no induction of laminitis. Now this bar graph shows on the y-axis percentage of horses that had either supportive or non-supportive test results. In the pink bars would be normal or non-supportive test results. In the blue bars are the percentage of horses that had abnormal test results. And what we can see is this nice peak in August, starting in about July through October, where we had a lot of test results that suggested Cushing's disease in horses, again, that didn't have clinical signs. And so in the fall here, we have a nice end summer, early autumn time when this test is not really useful for diagnosis of Cushing's disease. So we have to be careful that time of year. So the take-home message is for both ACTH and the dexamethasone suppression test is that the seasonal variation in activity of what I call the HPA, or the hypothalamic pituitary adrenal axis, complicates diagnostic testing at that time of year. So it's sort of difficult to test at that time of year. However, during this time of year, if you have a normal result or normal suppression or normal ACTH, then that is good news. It suggests that the horse doesn't have the disease. But a positive test result, failure to suppress, or a high ACTH, can be misleading at that time of year. So in general, we don't pursue a lot of endocrine testing from mid-July to mid-November for horses or equids in the northern hemisphere, and we rely primarily on clinical signs at this time of year. You can go ahead and test, and again, a non-supportive test would say it's probably unlikely the horse has Cushing's disease, but the positive test is difficult to interpret at this time. Okay. So that gets us back to diagnosis and what really constitutes a gold standard because of this problems in our hormonal measurements. If we go back to our term, pituitary pars intermedia dysfunction, dysfunction to me equates that we should have some clinical signs. Laminitis we're dealing with, or we have hirsutism. So I like to see the presence of both clinical signs and supportive endocrine test results. Other investigators say, well, the gold standard is pathology, evidence of disease, looking at the pituitary gland under the microscope and saying, aha, there's disease. Unfortunately, that doesn't help us out because we can't really do that diagnostic test in our live horses. And also, complicating looking at the pathology of the disease is some of the work, again, of Han van der Kolk at Utrecht. I mentioned his name again at the very beginning. So again, to emphasize, we want to have clinical signs. I'm going to show you again, this is work that Han van der Kolk did, and what he looked at was the pituitary glands of 100 normal horses. And these were varying in age, and they were in both sexes. And what he found is he basically, these horses had to be put to sleep for other reasons besides Cushing's disease, so they didn't have any signs of Cushing's disease. And at the autopsy, they looked at the pituitary gland, and they found that it ranged in size from 2.3 to 4.8 grams. That's relatively small. It's about the size of the end of your thumb. And it was largest in late gestation mares. So with the hormonal activity of pregnancy, the gland got bigger. Then they looked microscopically at those glands and looked for lesions in both what's called here the PD, the pars distalis, the area, or the pars anterior, that would be the disease area in dogs and man, as well as the pars intermedia. And they found that what they found here, if you look in these boxes, again, underlying here, they are without clinical signs of Cushing's disease, but these are the percentage of the horses that had lesions. And so if we look at the column here on the right, we found that 60% of the mares, 73% of the geldings, and 40% of the stallions had evidence of disease when we looked under the microscope. So this supports that it's a slowly progressive disease and changes occur as horses age, but not all of these horses are ever going to develop outward clinical signs. So it also tells us that looking just at the microscopic evaluation on the autopsy floor is also not a gold standard diagnosis for Cushing's disease. They did look at pituitary glands in this study also of 19 horses and 17 ponies that did have clinical signs. And what they found, not surprisingly, is that the gland was much bigger, one as big as 14 grams. So this is twice the size or more of the non-affected horses, and again supports both hyperplasia, or an increase in size, as well as adenoma formation. They also found no sex difference and no relationship with age. Okay. In other words, the pituitary gland could have been, enlarged in a 25-year-old horse or a 15-year-old horse, and it did not really necessarily increase with age as they had clinical signs. Interestingly, they also found no relationship between the size of the pituitary gland and the severity of clinical signs or laboratory abnormalities, the endocrine tests. So the size of the gland really doesn't seem to matter in terms of how big it is, but it is big in the horses with Cushing's disease. So take home message 3. Hirsutism, or the long hair coat, is actually the most accurate diagnostic feature. A group of researchers at the University of Tennessee did a comparison paper looking at ACTH and the Dexamethasone Suppression test and just this clinical sign, and found it was the most accurate. So why even bother to test further? Well, I think we like to test the get some endocrine test results to use it as a baseline to look at, is our treatment being effective? Is our treatment getting the hormone abnormalities back to normal? We can argue that you may not need to test initially, but after a couple of months on treatment, it is worthwhile testing, and I'll show you some information why I think that is. Overnight dexamethasone suppression test is probably most clinicians' preference because they're most comfortable with it, and cortisol is simple to test. The other reason we tend to prefer it is it's, again, this dynamic test. We're testing the response to the system to the dose of cortisone or dexamethasone. For follow-up testing, we've also simplified this to one visit, in which we actually tell veterinarians or recommend that veterinarians can dispense the injection of dexamethasone to you, the horse owner. You can give it in the muscle the afternoon before, and the veterinarian comes out the following morning. We don't like to do that for the initial test because we like to evaluate the horse and do some other blood work which the dexamethasone could alter. But for follow-up testing, this can be done. Plasma ACTH concentration can be useful in select cases. It appears to be less useful for monitoring progression of disease, again, because the magnitude of the elevation can be variable. And again, we have a little bit more difficulty with sample handling. Now, early on, I talked about insulin resistance as one other thing that can affect horses with Cushing's disease. And Kathy McGowan, a researcher from Australia, did find that horses at the initial evaluation, if they had elevated insulin in their blood, supporting insulin resistance, that they tended not to do as well long term. So looking whether or not we have insulin resistance at the initial evaluation might be useful for prognosis, because it might suggest that this horse might not do as well over time compared to a horse with Cushing's disease that does not have associated insulin resistance. Okay. So that's it for sort of our diagnostic challenges. I'm going to spend the last few minutes talking about treatment challenges. Right now, one of the questions is, what's the best treatment? And before we think about treatment equating to drugs, how about just simply management changes? How about body clipping, improved nutrition, and dentistry? And that might actually be quite useful for many horses in the earlier stages of the disease versus just starting on medication as soon as the diagnosis is made. So a question is, when should medications be started? And I think we'd like to handle that on a case-by-case basis based on the owner's goal and also their finances. What medication should be used? The pergolide, cyproheptadine, and trilostane are the three options, and we'll show some information that suggests pergolide is clearly the superior drug. Because of the cost, we now often use drugs prepared by compounding pharmacies, and as many of you are aware, the pergolide, actually the human product, was taken off the market because of some heart valve problems that occurred in people. Those people were getting treated with considerably higher doses of the drug on a body weight basis, so that's really of minimal concern, I think, in horses, and we're hoping to get that drug back on the market, but in the meantime we're left with the compounded drugs. Another question that we don't know the answer to is, do we have to treat them continuously year-round? Could we strategically target treating them just in the fall months where the hormone axis is more active? And the answer to that right now, unfortunately, is we don't know. We did a project a few years ago called the Michigan Cushing's Project. And in that project, we basically wanted to know whether pergolide or cyproheptadine, the two drugs that were commonly being used back then, which one was better. And what we did is we enrolled horses. A few of the horses came to MSU, but most of them were evaluated by veterinarians in the field. And basically, the veterinarians and the clients decided if we had test results supporting Cushing's disease, whether or not we would treat with cyproheptadine or pergolide. I also tried to recruit a few horses where we just had no treatment, so we had a no treatment comparison group. And we had 5 horses in the no treatment group, 7 horses in the cyproheptadine group, and 20 in the pergolide group. And in one of our follow-up assessments, this was either at 6 months to 12 months of treatment, we asked the owner, that would be you, is your horse simply better, improved in the pink? Has it gotten worse? Has it deteriorated in the green boxes? Or is it unchanged? Basically no difference. And if we looked at the result, we found that 3 of the cipreptidine-treated horses were reported to be unchanged. The blue bars here unchanged. 3 were improved, and 1 deteriorated. And we found, when we looked at the Pergolide-treated horses, there was a clear difference. 17 out of these 20 horses were reported to be better by their owners. And the little asterisk says this was a statistically significant finding. So clinically, they recognized much more improvement with Pergolide than with cipreptidine. We also looked at the testing. So these horses entered the study if they had supportive overnight dexamethasone test results, were our category for looking at for Cushing's disease. What we have here are the first series of bars, or simply one bar, because all of them at the start, at the pre-period, had test results supporting of the disease. And we wanted to see, after 6 to 12 months of treatment, what did the test results do? Well, surprisingly, with no treatment, one of them actually developed a non-supportive test result, and that may have been one of the seasonal variations. This study was done in the late 1990s and early 2000, and so it was before we understood the seasonal variation. Cipreptidine, only one horse also had the test result turned back to normal. In contrast, 7 of the Pergolide-treated horses had the test result turned back to normal in this pink bar, yet 13 continued to have abnormal test results. Now remember, 17 of these horses were reported to be better by their owners, but only 7 had an improvement in test results, and this is one of the reasons we recommend doing follow-up testing, because we can adjust the dose of medication to try to get these more normal. This was a single dose study. They only received 1 milligram of Pergolide per day to the average 1,000-pound horse. We did not increase the dosage during this portion of the study. If we looked at the other hormone, ACTH, which we did measure, we could see the Pergolide-treated horses were the only group that had a decrease in the ACTH. The line here going across at 10 is the normal range, so they still were a bit elevated, but it's the only group where we had improvement in ACTH. Okay. Blood glucose or blood sugar concentration can sometimes be elevated in Cushing's disease as well, and we can see again with the Pergolide treatment here on the right, Pergolide was the only one that had a decrease in the blood sugar concentration. So these findings clearly support Pergolide did better than cipreptidine. In summary, this project showed us that both owner assessment of improvement, or the improvement in clinical signs, might be due in part simply to improvements in overall health care. When the diagnosis is initially made, usually there's some discussions with your veterinarian about improving nutrition. Some dentistry is often performed, so some of the improvement may be related to that. And that improvement alone may not be a reliable indicator of response to medical treatment of the PPID. In other words, the endocrine test results may still remain abnormal. The results clearly supported that Pergolide is more effective than cipreptidine. At the time we were doing this study, a group at Cornell, as well as a group, again, Mark Donaldson, was looking at this at New Bolton Center. And he looked at ACTH concentration in his horses, and he looked again before and after treatment. Very coincidentally, he also had 20 horses treated with Pergolide and 7 horses treated with cipreptidine. So we're going to look here at the second column, the ACTH, and he had an elevation in ACTH in his 20 horses and found a significant decrease in the Pergolide post-treatment here. In terms of, he also measured insulin, and there was no significant change in insulin. And the blood sugar over on the right-hand column also tended to decrease with the Pergolide treatment. In contrast, with cipreptidine treatment, the bottom 2 rows, there was no decrease in ACTH really, and there was no significant really improvement in blood glucose or change there. The insulin did go down, but there was a wide range here, as you can see in the parentheses below. But this study also showed that Pergolide was a better treatment than cipreptidine. The final study out of Cornell had less numbers of horses, but also showed Pergolide was better. So what is Pergolide? Pergolide is a dopamine receptor agonist. That means it acts like dopamine on these receptors in the hypothalamus and tries to stimulate those nerves to try to control that production of POMC by the abnormal pars intermedia of the pituitary glands, so it decreases that. The advantages of this drug, again, best treatment response in 3 independent studies, and it's a simple once-daily medication. Disadvantages of this drug: there's no approved product on the market for horses. The Permax, the human product, is now off the market. So we're all using it as off-label, and we're using these compounded products to try to decrease the cost. We're somewhere between $0.50 and $1 a day through the compounded pharmacies for 1 milligram of Pergolide. Adverse effects occur, but they're relatively uncommon. The biggest problem we see is that when we first put horses on it, sometimes they'll be off feed for a little bit. About 10% of horses might back off on their diet. If that occurs, we simply stop the medication for 3 or 4 days and start back at half the dose for a week or 2, and then bump it up. Again, there's no evidence that there's any heart valve problems in horses, as has been described in people. Again, the dose tends to be lower in horses on a body weight basis. Early on, people thought that maybe this could exacerbate the founder laminitis. Again, there's no evidence of that. How about our cyproheptadine? Well, our cyproheptadine is the other serotonin antagonist, so it has a different way that it might decrease the POMC production. About 10 or 15 years ago, the advantages were it was a lot less expensive than Pergolide, so we often selected that first, and the Pergolide was more expensive. Another advantage now currently is the price of cyproheptadine, unfortunately, has gone up. It could be synergistic with Pergolide. Again, the disadvantages of it, in those 3 case series, it didn't have much efficacy. Just like Pergolide, there's no approved product, and we don't have any sort of pharmacological data on either of these drugs. In other words, the blood concentrations. Price is increasing, so if it's used, the compounded products are used. And if we have higher doses of it, it's a little bit of a sedative. It's an antihistamine type drug as well, and so it might have a little sedation, drowsiness effect, but usually not at the dose we're doing for Cushing's disease. Okay. Trilostane is the other drug that, again, we can't use commonly here in the U.S. We have to get a special use permit to use it. The idea behind it is it, again, works at the level of the adrenal cortex where the extra cortisol is being produced. In theory, it could be used with Pergolide, but it probably should not be your first line of treatment. It's quite expensive as well. It's even more expensive than Pergolide or cyproheptadine. Okay, there is some work that Kathy McGowan has done with this, but the efficacy data in those publications is not very convincing in my opinion, so we don't recommend this drug certainly as a first-line treatment. Okay, now how about all the other stuff? How about herbal products? How about homeopathic products? There was one that used to be used called Hormonize, and that product is now called Evitex, and it's a mixture of several herbs. And predominantly in there, it's a Vitis agnus castus extract or chasteberry extract. Actually, that's the predominant thing in this. Well, there was a group in the United Kingdom headed up by a veterinarian. This is an advertisement, and they enrolled 120 horses and ponies between 2001 and March of 2004. These horses had both clinical signs and they had an elevated ACTH concentration, and they were treated for a year. On their website that you can go to, they have a preliminary report published in December of 2004, and as I have recently checked, they've not updated this. They had 25 horses were to complete the study, and they said 22 had improved hair shedding, and they had fewer bouts of laminitis. But unfortunately, there was no change in any of the hormone concentrations that they measured. Mark Donaldson and Jill Beach at University of Pennsylvania's New Bolton Center did another study that they presented in 2002. They used the product when it was called Hormonize, and they had 14 horses treated for 2 to 6 months, and during that study 13 out of the 14 deteriorated. And when the Hormonize product was still on the market and there was a website for it, what was interesting about it is you would read through the case testimonials in there, and sometimes when the horses were having sort of a deterioration, they actually put them on Pergolide for a month or 2. So I don't think we have very good evidence to say that this product should be used as the primary treatment. Okay, lots of other things have been used over the years. Mechanisms of action largely unknown, and a lot of data is not really available. In addition, you may want to have feed supplements, things like chromium for the laminitis and other things. Again, we have very limited data on those types of products. So our recommendation is to spend your money on pergolide first before pursuing these other undocumented treatments. So again, that leads me to my take-home message, the final one. Clients, I recommend you should spend your resources on improving management, get the nutrition under control, maybe start to feed one of the senior diets, get a good equine dentist out there, and perhaps use some body clipping. And if you're going to choose a medication, we recommend starting with pergolide before any of the other undocumented treatments are pursued. If you want to use the other treatments, that's fine, as long as you've done this top 3 lines first, because as far as we can tell right now, we may just be wasting money with these undocumented treatments. Okay, so in summary, our initial evaluation, what we like to do for you as clients is do a good clinical exam, document what clinical signs are present, and get a weight of the horse either by a weight tape and do a body condition score. And for you that are unfamiliar with the body condition scoring system, this is one just example where we look for the body condition and fat reserves. I'd be happy to post a more detailed information on this, and this is something you can do and should get in the habit of doing with your horses several times a year. We do like to do a blood count and look at a chemistry, especially a blood sugar or blood glucose concentration. And even if the horse hasn't had any evidence of founder, side-to-side front foot x-rays might reveal that there has been some changes there, even though there's no signs of pain. So if we want to do the best possible exam, we would do all these types of things. And then for endocrinologic tests, I recommend the overnight dexamethasone suppression test, the insulin, would be my 2. Again, it depends on the season. We wouldn't do these in the late summer and fall, and an overall nutritional evaluation. Treatment approach, I think we need to make this individualized for each horse and client. Many of the horses could do well if they don't have any laminitis with management alone, body clipping for 2 or 3 years before medication is pursued. Certainly we could suggest that if we, in the first instance of signs of the disease, if we started them on pergolide on day 1, maybe it would slow the progression and make the horse do better for the next 8 to 10 years. So you can make an argument for starting on medication right away or delaying it, depending on the severity of clinical signs, and also depending on your financial resources. I like a twice annual reassessment if things are going well, December and May, which are months where we could test. Clinical exam measuring the blood sugar, glucose, and endocrine testing. If we're having abnormal endocrine test results, we would up the medication dosage, usually by 0.5 milligram to 1 milligram a day of pergolide, and then retest in 30 to 60 days. And I think we're nearing the end here, and some of the persisting questions, again, when should treatment be started? I think right now we only can base that on our opinions, and again, I'd like to tailor it to an individual horse. I'd like to know if treatment could be intermittent. Could we treat them just for 3 to 6 months in the fall? That's a study we tried to get started a few years ago here at Michigan State, and the problem with that is we're going to have to treat a number of horses for probably more than 5 years before we can answer that question, so a very difficult study to complete. Should we use single, just pergolide, or combination drug treatment? Clinically, when I get horses that don't respond when the dosage of pergolide has been increased to 3 milligrams per day, at that time I usually do add cyproheptadine to the drug treatment plan and do it as a double-pronged approach, but stick with pergolide initially. How about prognosis? How can we tell you how your horse is going to do? Okay, some information again exists that if we have an elevated blood sugar or diabetes and elevated insulin at the start, these horses tend to do poorer long term. Other things that have been my subjective impression that sort of makes sense is if we have a horse that has serious clinical signs between 15 and 20 years of age rather than starting between 25 and 30 years of age, my impression and experience has been that the younger horses are more difficult to control and have done worse over the next few months to years. Okay. Another thing is just the initial response to treatment over the initial 60 to 90 days. I think that can be helpful. If we have a really favorable response, those horses seem to do better. If they don't respond very well and we're having to up the dosage of the medication in the first 6 months to 2 and 3 milligrams, prognosis tends to be more guarded. Just to end up here, this is a horse that we've worked with here. It's a 27-year-old Morgan gelding. It's been treated with pergolide for more than 9 years, and he's had some chronic laminitis was the initial clinical sign, but he sheds out pretty nicely now, and he's doing pretty well. So they can go a long time on this. The difficulty with this is they've spent over $10,000 on Pergolide over this 9-year period. And so when we're looking at what's the best for this long term on this horse, we really have to take it in consideration when we look at the financial aspect of it. And I think at that point, be willing to answer a few questions and turn it over to Kate, I guess. Okay, I'm seeing some questions come in. Are there feeding strategies to prevent or delay Cushing's? Not any that are well documented that actually can reverse it. Just general increase or nutritional programs for older horses where we can have they have difficulty in chewing and digesting hay and masticating it or chewing it very well. So looking at the more senior products, all the other feed supplements that are out there, there is potential that they may be of some benefit, but none of them are validated or documented. Okay. Is it possible that a horse has all the clinical signs, shaggy coat, laminitis, abnormal fat, but a normal ACTH and a normal dexamethasone suppression test results? It's always possible. There are exceptions to all those rules. In that situation, I would recommend just body clipping the horse unless the laminitis is fairly serious. In that situation, we often try Pergolide for 3 months or so to see if it helps get the laminitis under control. Okay? Is this okay? Kate, just double checking that it's okay that I answer these questions verbally rather than typing. Okay. The next question I have here is that, excuse me, I'm going to go back up here. I heard equine senior is actually bad for Cushing's horses. I would tend to disagree with that. Again, you need to develop a nutritional program targeted for each of your horses. Certainly, if the horse can be maintained on a hay diet only, that is ideal. We usually only move on to the senior diets when chewing is limiting their hay intake. Is there any genetic research in Morgan bloodlines to determine which lines are predominant with Cushing's? Not to my knowledge at this time. I'm not aware of any. Okay. I have a 10-year-old Welsh pony who has already grown a very thick coat and a cresty neck. Is it possible for her to develop Cushing's now, or is it more likely that she would develop it later on? Well, the earliest documented horses and ponies with Cushing's are about 7 years of age. Okay? The first thing that I would recommend in a situation like that is to try to get some weight off of the horse and keep it a little bit more on the lean and mean side, a body condition score of 4.5 to 5. Certainly, you could test the horse with a dexamethasone suppression test or an ACTH and see what the results are, and it is possible, though less common, to have it only 10 years old. I always have to ask with ponies, are we sure it's just 10 years old? You know, if it's a Welsh pony with papers, then you can believe it, but it's awful difficult sometimes to know if they're truly 10 or 15 years old just by looking at their teeth. Would a Cushing's horse always be hypothyroid? No, and that's been fairly clearly shown by work done at the University of Tennessee. Hypothyroidism appears to be extremely rare in horses. When we test the thyroid gland with a dynamic test and stimulate it, it shows good output of thyroid hormones. Cushing's horses sometimes are confused as hypothyroid, but again, it is extremely rare and undocumented that they have hypothyroidism. The so-called metabolic syndrome or insulin-resistant syndrome horses may commonly have low resting thyroid hormone concentrations. But Nicholas Frank at the University of Tennessee has done some extensive work there and shows that they are not hypothyroid, although thyroid supplementation can be used to help with weight loss. So we can actually use thyroid hormone supplementation as a diet pill for horses. My preference is to limit their hay intake rather than give them medicine to get the weight off, but it can be used to help with that in these very easy keeper horses. Okay. What was the best kind of hay? Well, really, the best kind of hay is going to be probably a grass hay that can maintain the horse's body weight. something like that. And I think we're over here and the end of the presentation. I'll try to answer this question. They keep coming in here, and we'll see. Laminitis in a 10-year-old horse with a normal coat and body condition score of 6. Dex suppression mildly positive in September. Again, I think that's a seasonal influence there. The testing can be affected in December. Should you try Pergolide? I don't think you need to at 10 years of age with a normal coat. I think you have more the metabolic syndrome, insulin resistance syndrome. Okay.
Hal, I just wanted to thank you so much for being our expert speaker tonight. We will have this presentation on the archive section of the web presentations on the myhorseuniversity.com website, and the website's right on your screen right now. You can also email info@myhorseuniversity.com, and then our client services phone number is on there as well. We appreciate you all attending, and our next web presentation is actually on hay selection, so that was a good question to end with. So if you are interested in signing up for that, please also go to the website for that. And Dr. Schott will also be working with us on the equine health course that will be coming out later summer, later fall, and you can get updated on our online courses through signing up for our e-tips on our website as well. And I just wanted to thank you very much for attending, and we look forward to having you again. Have a great night.